Hi, my name is Fernando Dominguez and I'm a consultant cardiologist from the Hospital Puerta de Hierro in Madrid, Spain. I'm going to talk to you about hypertrophic cardiomyopathy. More specifically, I would like to show you some slides on the definition, etiology, and diagnostic workup of this disease. This is how hypertrophic cardiomyopathy looks like. So it's a thick heart. It can be both in the left or the right ventricle, and it was first described by Donald Terr, a British pathologist, in the 1950s. He already described the familial nature of this disease, as these were cases of sudden cardiac death in the same family. He also related it to disarray because he not only described the macroscopic findings but also showed that the muscular fibers were showing disarray. As you may know, hypertrophic cardiomyopathy is the most frequent inherited cardiac disease and the most frequent cause of sudden cardiac death in the young. The prevalence is estimated to be 1 in 500 people in different populations. In most cases, it has an autosomic dominant inheritance, and the annual mortality is more or less 1%. Most of the patients can have a good quality of life, but however, there are severe complications of the disease, such as sudden cardiac death, embolism, or heart failure. The definition of hypertrophic cardiomyopathy is an increased left ventricular wall thickness that is not solely explained by abnormal loading conditions. We mean by abnormal loading conditions hypertension, valve disease, or, for instance, coronary artery disease or some other or congenital diseases. In adults, is defined as more than 15 millimeters of the wall thickness. In children, is more than 2 standard deviations from predicted mean, so the Z score. Our first test we can run in a patient where we suspect hypertrophic cardiomyopathy is an ECG. So here you can see an example where you can see very high voltages in the QRS and also very peaked T waves. However, there are several types of hypertrophic cardiomyopathy and some phenocopies that can show different characteristics in the ECG. For instance, if we find a short PR interval or pre-excitation, that might mean that we are having a storage disease, for instance, Pompe, PRKG2, or Dannon's, as well as mitochondrial disorders. A patient with hypertrophic cardiomyopathy and AV block that might be we might be having some cases of Anderson-Fabry disease, amyloidosis, dysminopathies, or PRKG2 mutations. When we find extreme left ventricular hypertrophy, so a circular score more than 50, that's typical of some cases such as Danon disease. Low QRS voltage or normal voltages despite increased LV wall thickness, that's typical of amyloidosis patients, although it's not found in all the patients with amyloidosis. Other characteristics or red flags that we might see in the ECG are giant negative T waves inversion that may be suggestive of an apical hypertrophy. Another very important test that we can run in patients with a suspicion of hypertrophic cardiomyopathy is echocardiography. Here we have several aspects that would need to be assessed. For instance, wall thickness, left atria, LVOT obstruction, and diastolic function. Wall thickness is important to be directed. We need to measure it in the right place. It has to be measured in end diastole and also in the short axis view. We kind of measure it in the four chamber apical view or in the long axis view because we might have misleading results. It is also important in these patients to see the evolutive changes along the years, to see what's changing regarding the obstruction or the thickness or the atria, for instance. And also, it's very important to consider age and sex, as well as body mass index, in order to adjust the different parameters. Here we've got an example of where the wall thickness should be measured, and we can see that, as I told you before, it has to be in the short axis view, and especially here we can see in the different regions. We can see the more basal, the mid segments, and the apical segments. Another important test in order to diagnose hypertrophic cardiomyopathy is a cardiac CMR. Normally, with the echocardiography, we can already have a diagnosis, but for instance, with back window acquisition, so if we want to assess a specific etiology, MRI might be very, very useful. Once the diagnosis of HCM is already established, we can these tests can help us with the typical forms of HCM. For instance, apical HCM, apical aneurysms, atypical patterns of hypertrophy, or the right ventricular involvement. If we have an uncertain diagnosis of HCM, MRI can be extremely useful in order to, for instance, to show us the patterns of the late gadolinium enhancement, and therefore to give us a differential diagnosis between hypertensive heart disease, aortic stenosis, athlete's heart, infiltrative diseases, or other cases. MRI is also important in order to plan treatments, preprocedural planning in case of myectomy or mitral valve repair, and also post-procedural planning just to see how the procedure went. And also, it's important to assess prognosis with the septal dimension and with the late gadolinium enhancement. We can have hints of what the prognosis of the patient could be. Here you can see different images of MRI in patients with left ventricular hypertrophy. The first case is hypersensitive cardiomyopathy, where you can see some gadolinium enhancement just in the basal septum. However, in the second case, you can see hypertrophic cardiomyopathy with an extensive fibrosis in all the hypertrophic segments, which is typical of this disease and that can make a differential diagnosis with hypertension. In the third case, you can see Fabry's disease. This Fabry disease is a metabolic disease with accumulation of a glucose sphingolipid, and you can see that the late gadolinium enhancement is in the lateral wall. This is quite typical. In the fourth case, you can see cardiac amyloidosis. MRI can be very useful too in these cases because cardiac amyloidosis has a typical behavior of the gadolinium kinetics, and also you can see a typical enhancement with the subendocardial layers being having this LGE in this case. Some other tests that can be used to diagnose the different types of hypertrophic cardiomyopathy can be bone scintigraphy. In cases of TTR amyloidosis, this can be diagnostic when we have an uptake, a specific uptake, and also endomyocardial biopsy. This may be considered when the results of the other tests suggest that we may be having a storage disease or an infiltrative disease. So in these cases, endomyocardial biopsies can be helpful in order to tailor the specific treatment of the patients. Moving on to etiology, the cause of hypertrophic cardiomyopathy can be very varied. The most common cause is sarcomeric protein disease, with the different genes involved in the sarcomere that can be the cause of the mutations in these genes can be the cause of HCM. For instance, beta-myosin heavy chain or cardiomyosin binding protein C are the most common genes involved. We also have syndromic HCM with different syndromes that cause left ventricular hypertrophy, such as Noonan syndrome, Leopard syndrome, or Friedreich's ataxia. And also we have metabolic disease with the different storage diseases that can cause left ventricular hypertrophy, such as Pompe's disease, Anderson-Fabry's disease, or some other cases of, for instance, mitochondrial cytopathy, such as MELAS or MERV or LUN. Here you can see 4 cases of left ventricular hypertrophy, and as I will show you later on, these are caused by very, very different diseases. In these images we have amyloidosis, we have Fabry, we have sarcomeric hypertrophic cardiomyopathy, and just with the image you cannot distinguish it. So you will need to perform some other tests in order to reach the etiologic diagnosis and give the patient a specific treatment. The causes of left ventricular hypertrophy, as I'm telling you, can be genetic, metabolic, but also physiological, with hypertension, aortic valve disease, or even in athletes' hearts. The most important is sarcomere disease. As I told you before, this is the most common cause of hypertrophic cardiomyopathy. This is the sarcomere, and you can see the different proteins that are involved in the sarcomeres. And the genes that produce these proteins are those whose mutations can cause HCM. However, although most cases are caused by sarcomere gene mutations, some others are not, and it is very important to distinguish this in order to establish a specific treatment. For instance, these belong to 2 different patients with a similar echo, but however, we have after performing an endomyocardial biopsy, we have sarcomeric HCM in the first image caused by a mutation in MAY-BP3, and the second case is in metabolic HCM due to a mutations in LAMP2. So, according to the definition established by the Americans, we can have hypertrophic cardiomyopathy due to a sarcomere mutations, or otherwise we can have also syndromes with LVH, left ventricular hypertrophy, due to systemic, metabolic, or multi-organ syndromes. So, coming back to the 4 images I showed you before, the first case was sarcomeric HCM, the second case was TTR amyloidosis, the third one was Fabry disease, and the fourth Danon disease. And you know that all these 4 diseases have different treatments, so it's important in this case. In this case, it was very important the genetics and also the histology. In order to reach the diagnosis, we should therefore consider genetic testing in some of the in all the cases. Because it's very important to distinguish the sarcometic disease from other phenocopies. The phenocopies are all the other diseases that mimic sarcomeric HCM, but however is caused by some other disorders, and as we can see here, such as mitochondrial disease, Leopard syndrome, amyloidosis. Why is this important? Should we diagnose phenocopies? Because of these therapeutic implications, the familial implications, and prognosis. Here you can see the prognosis of sarcomeric HCM versus phenocopies, and you can see that it's worse in phenocopies, so we need to diagnose these patients early. And even if we make subgroups with these phenocopies, we can see that some cases such as amyloidosis have a worse prognosis than some other cases such as Anderson-Fabry disease. And it's also important because we have more therapies, more specific therapies for these patients. So it's really important to reach the etiological diagnosis. For instance, these phenocopy could be Fabry disease. This is 1% of HCM is linked to the X chromosome. It's caused by mutations in the GLA gene, and you can have involvement of the heart, of the kidney, and also neurological. Downs disease. This is also an X-linked disease caused by mutations in the LAMP2 gene. As therefore, males are more severely affected. In women, it can cause a more mild disease, and it can even cause a DZM phenotype. And it's important to assess in the labs CPK and also the liver enzymes, because they are usually increased. And the ECG is typically it shows pre-excitation. PRKT2 is also a phenocopy of sarcomeric HCM, which also shows pre-excitations in the ECG. Amyloidosis. We can also have extracardiac findings. For instance, in hereditary TTR amyloidosis, we can have a neurological involvement, and in AL amyloidosis, we have a systemic involvement. In Leopard syndrome, we can find dermatological lesions such as lentigens. We have facial abnormalities. We can also find deafness, retarded growth, and it's caused by mutations in PTPN11 and RAF1 gene. Also, the different phenocopies depend on, we can have the different cases depending on age. For instance, senile amyloidosis, wild-type TTR from 60 years old onwards, and in earlier diagnosed patients, we can find some syndromes such as Dannon's or Leopard's, for instance. This is an example of an ECG of Dannon's disease with extreme LV hypertrophy. This is an explanted heart from Dannon's disease. Here you can see PRKT2 with the pre-excitation pattern. And again, it's important to, whenever you want to diagnose the patients with left ventricular hypertrophy, to take into account in the blood work and the laboratory tests, you need to include some things that are not normally included in a routine lab test. So, for instance, lactate or the liver enzymes, or even screening for Fabry's for the alpha galactosidase enzyme when we assess a patient with hypertrophic cardiomyopathy. And just to end up, I want to underline the importance of the genetic study. That we can find mutations in 40 to 60% of patients, sarcomeric gene mutations, and in other 5 to 10% of patients, we need to find these other etiologies that I've been mentioning before, these other phenocopies. So thank you very much for your attention.